What I'd like to do now is introduce our keynote speaker. Saleem Razack will be speaking this morning, and Dr. Razack is a practicing pediatric intensive care physician and professor of pediatrics and health sciences education at McGill University and Montreal Children's Hospital in Montreal, Canada. He is the inaugural director of McGill's Office of Social Accountability and Community Engagement and is a member of McGill's Institute for Health Sciences Education. His research interests in health professions education broadly concern issues of equity, diversity, inclusion, and anti-racism, which he studies through both qualitative and quantitative methods. Today, he will be discussing a new definition of professionalism. Welcome, Dr. Razack.
Hello, please lift your thumb if you can hear me. Thank you, thank you. It's such a pleasure to be here. It's sad that it's not in person, but it is not without some good points. I've only had to dress from the waist up in order to give this keynote, though as I was saying earlier, I'm actually at my place in the country, and I came up here and I realized there's no blazer and there's no tie, but at least there was a white shirt. So please forgive me for that, and please understand that that was my mistake. I want to just give a little gush of appreciation to the Academy for Professionalism in Healthcare. I did not know about this organization until about 2 years ago. I got kind of a little bit involved in the conference and so on in 2019. And I have really felt that this is an organization that may advance critical thinking around professionalism in the health professions. That is why I continue to be involved. What I hope to talk about today is really to get us thinking about how we construct professionalism and socially construct professionalism, and how it might need to evolve for what I will argue is really quite a new context that we're in right now. This is actually outside my window. This is outside my window in fall, autumn, but it reminds me to do something that we often do in Canada, and which is actually important, which is to acknowledge that I'm giving this talk from, unceded territory. This is the traditional territory where I am right now. Is the traditional territory of the Algonquin people. Sometimes when I do this, I feel like I'm performing because it's really something that's required in the Canadian context, particularly in a talk about equity and professionalism. But I'm not performing. I want to tell you that what I hope to do today is my own personal act of truth and reconciliation through this talk, and to really get you thinking. I have no conflicts of interest to declare, and I think it's important to really talk about safety today. I don't think I hope the talk doesn't go there, but I think it's really important to really acknowledge that we will talk about some things that may trigger you, that may uncover stereotypes and prejudices, may put you in a zone of proximal discomfort. And in fact, transformative learning only happens in the place of proximal discomfort. In terms of specifically the triggers, there are 1 or 2 slides where I talk about medicine and Indigenous people, medicine and Black people, medicine and medicine that might affect a person who has direct familial history with Nazi Germany, for instance. And I will try to remember that those things are coming, and make sure that you are aware. I think this is the last slide before we dive in. But I think in a talk about where someone is presenting or thinking of trying to get you to think differently about professionalism, I think it's really important to explicitly declare a kind of a critical reflexivity of where you're coming from, so that you know. I mean, it's not the whole story. I'm 56 years old, so it would take 56 years to tell you the whole story. But I think what I'd like to really tell you is the formative influences on me with respect to becoming a doctor and thinking about equity, diversity, inclusion, and professionalism. So, you know, I owe everything to this place, which is Trinidad and Tobago, which is where my family is from. And what's important for you to know is, from a historical perspective, is that my family is only there. There is only someone who has a name like Saleem Razack there, because African slavery ended in the British Empire. And at the same time, the British were expanding in India and created this new system of servitude called indentureship. So my family is descended from Indian indentureship. And I think what this country has given me is an appreciation of how history affects the present. And also how, you know, like my particular version of being Indian is only meaningful because it's grown up as a version among our friends and neighbors, you know, the descendants of African slaves, and many others actually. And then, you know, I'm an immigrant. My family emigrated to Toronto when I was a kid. And what I'd like to say about that and what's important about that for this talk is, and this will maybe not speak to many of you, maybe some of the Canadians, but I became a Canadian watching American TV coming from my nearest city, which was Buffalo, New York, which was where our ABC, NBC, and CBS came from, and we would never watch Canadian TV because it wasn't, you know, entertaining. And, you know, I'm so nostalgic for this kind of TV, and I've put a picture of my favorite show, Mary Tyler Moore. But I think what's important to note is that on TV, they were selling whiteness. And there was this kind of idea of that in television. And it really blinded me to the inequities of my own country, which has been a lot of where I go. The last thing, there's a picture of C3PO and R2D2. I think it's important for you to know that I belong to the LGBT community, and that's given me a unique perspective. I think everybody has a unique perspective, but for me, C3PO and R2D2 are perhaps an example of a love story that nobody's ever talked about. So today, the questions for us to consider, I want us to consider professionalism as a social construct. What are the elements of this social construct? What might be the knowledge power relations in there? And because there are knowledge power relations in all social constructs, how does this affect equity, diversity, and inclusion? And then in this year that we have all just lived, I don't even want to talk about it too much because it's been such a year, you know, where we appreciate so much more equity, diversity, and inclusion issues. Do we need a new formulation? So I'm going to start with 3 cases. So the first case is Jamal. So he's an 11-year-old boy. He is what you in the United States would call African-American. And you know, this is in the intensive care unit where I work. I'm an intensive care doctor. And he spent a number of days in the intensive care unit, and he actually drowned and was resuscitated, and he ultimately succumbed to his injuries. So in the intensive care unit, we discuss cases every month where there have been problems in the care, and we review all of the patients who have died, the care of all of the patients who have died, to see if there's something to learn from it. We call those morbidity and mortality rounds. And so he's being discussed, and then two of the attendings have this kind of discussion in between themselves where they say, this is the fourth Black child in the last 3 years who has drowned and in our unit. You know, how is that happening? What is the social determination of that? And they raise this issue, and it doesn't really go further than that. It stops there. And you know, when I teach about that, I often teach about the AIDS crisis, which defines my generation of medical students for sure. You know, AIDS would be nowhere, HIV treatment would be nowhere without, you know, family practices in New York and San Francisco noticing patterns of Kaposi's sarcoma, for instance, and then alerting the public health authorities, right? So I think a question here is, what is the responsibility of the physician to notice? And perhaps what is the responsibility of the physician to do? The second case is Neville. So Neville is a 22-year-old with myotonic dystrophy, means that he has muscle weakness that is inherited, and which moves him, which causes him to be in a wheelchair, and he has respiratory ailments that he is more prone to respiratory ailments that require admission. So he's admitted with a respiratory illness, and he's being discussed at discharge planning rounds. And at discharge planning rounds, the group is talking, and they say, which is sort of includes the nurses, the doctors, the social workers, some of the psychosocial support team for the family, and the conversation gets quite judgmental. They say that Neville is ready for discharge, but that his parents, who look at his mother and his grandfather, who look after him, are you know, they want a break, so they're using hotel hospital. That's the word that's used, hotel hospital, in order to have a bit of a break from his care. So then a couple of weeks later, the medical student who was there at these rounds happens upon Neville, his mother and his grandfather at their place. And Neville's grandfather is lifting this 50-kilo child up 2 flights of stairs, because that is where he lives. And he asks Neville's grandfather, why do you have to lift him? Why don't you have, you know, an adapted chair? And he says, well, there's a 15-month waiting list for that. So the medical student immediately feels guilty about that. Then the third case is the case of Bill. And for those of you in Canada, this is a fictionalized version of Joyce Echaquan. Okay. So he's an Indigenous man, and he is admitted with alcohol intoxication. And he's in the ER, the emergency department, actually, the ED. He filmed racist interactions with ER staff, and he posted it to Facebook. Trust me, from the real case, it's really really major stuff that was said to him. And in fact, he actually succumbed to his injuries within hours of the postings. And on postmortem, he was found to have died from internal bleeding, so unrecognized trauma that was there. The medical school where the hospital is associated, you know, takes it very seriously and puts out one of these "We stand in solidarity with Indigenous people" statements, which is not very well received at all by the Indigenous community. They say, stop doing statements. We want you to do actions. So here, so in these 3 cases, if we analyze them through the lens of professionalism, for the case of Jamal, it's sort of this idea of you're noticing patterns. That's what we do in medicine. We notice patterns. We put things together. Then it becomes, what is your responsibility? What is your responsibility once you've noticed the pattern? Do I alert the public health authorities? Do I alert the trauma program so that they can work in partnership with the communities that we serve to try and understand the social determination of drowning in Black children? Just as an aside, for those of you that don't know the literature, there's actually quite a bit of literature that shows this. You know, it's all about who gets taught to swim, who lives near swimming pools, and all that kind of stuff. That's sort of one case. In the case of Neville, there's the situation where you're sort of thinking about, well, there was language that crossed a line in discharge planning rounds. And, you know, what is our role to address it, right? That's sort of a way to think about that through a lens of professionalism. And in the case of Bill, it's, you could sort of think, well, we have to hold those professionals accountable that were, you know, that were filmed doing, you know, engaging in racist interactions. And in fact, in this case, in ways that made them just see Bill as someone who was intoxicated rather than someone who had internal injuries that needed to be addressed. So, you know, what do I want to talk about? I want to talk about this last year and how it has completely changed my thinking about what it means to be a physician myself. Okay, and I hope I get you thinking about others. So, you know, in the center here is the COVID virus. Many of us who are physicians or health professionals, we have the experience of watching how in 2 weeks, every single process and procedure in our hospitals changed. And then 2 weeks later, they changed again related to COVID. And, you know, seeing our units fill up, I'm in pediatrics, so I did not see this as much. But seeing our units filled up with racialized people, for instance. And, you know, then we had the murder of George Floyd, which, and I wanted to recognize a trigger here, you know, because I think that persons who have experiences similar to George Floyd or have the potential for experiences similar to George Floyd, you know, did not come to new awareness around racism in Canada, in the US, around the world actually is what happened with George Floyd from this event, but other people did. And that can be a really tough pill to swallow. But that's another thing that occurred that really got countries thinking about racism. And in Canada has ignited this big discussion about systemic racism in medicine itself. Justice for Joyce. So Joyce Echaquan is an Indigenous woman who in my own province of Quebec was actually had a very similar occurrence to the case of Bill that I gave you, and which has given rise to a whole reaction around systemic anti-Indigenous racism in healthcare in Canada. So this has gotten me thinking, you know, and I always wondered, you know, when I got appointed at the Montreal Children's Hospital, I got privileges at the Montreal Children's Hospital. And I always wondered about this notion of privilege and, you know, being a professional with respect to that and how it's constructed. And I think, you know, when I sort of think about it and have researched it, we think about professionalism as a social contract. And in fact, this has been advanced and was advanced very significantly by two colleagues of mine to whom I owe a great deal personally, and who I missed because they have retired. I used to share an office right beside them, who are Richard and Sylvia Cruz, who really advanced the idea of the notion of a social contract. And the idea here is that we, and I'll speak as physicians, but I think it goes with other health professionals, we have special knowledge, and for that, we entreat to have obligations towards patients in exchange for some privilege within society, the privilege of having a voice that might be listened to more, and so on within society to do good. And, that's a kind of like a way of looking at it. And it's actually a way that worked for me for a very long time, but it's sort of not working as well for me now. And I think the last year has really shown it. And I think within it is this notion of noblesse oblige. And for those of you that are not as familiar with that term, this is the idea that if you're the lord of the manor, you have responsibilities to those who are less than you. That's the way it's sort of constructed in the nobility idea. But that's what I see now when I'm seeing this social contract as it is done. And, there's a rich literature on the discourses of professionalism that really sort of tease this apart, which I don't really have time to go into today. But I think what it sort of got me thinking about is how physicians are beneficiaries of healthcare systems. But the other thing is that these healthcare systems are designed explicitly to discriminate and be inequitable. So when when we see discrimination in healthcare, it's not because the system isn't working. It's actually because the system is working the way it should. So that some of what we need to be thinking about is how to dismantle. And that is why I think a new formulation of professionalism is necessary. We're prisoners of history. Actually, we are bound by history. And I don't want to be historically deterministic, because I think that we don't have to be defined by history, but we are bound by it. And I think that one of the things that has to happen for us is to recognize our profession as in full continuity with unjust histories. And I've given you some examples here, and here are the trigger warnings that are for people who may be descended from or may have been directly affected by the things that I'm going to talk about in a second here. So, in Canada, there were unethical nutrition studies on Indigenous people and children, where people were used as controls and allowed to starve in order to understand nutrition in all people. And I put this picture of pablum up, and pablum, for those of you that don't know, is an infant formula, an infant cereal that is basically, you can look at it as the precursor or the grandmother of all of the yuppie infant cereals that we see now. And I have 3-year-old twins, so I'm pretty close to it. And it was invented at the University of Toronto at the Hospital for Sick Children. And the patent still gives royalties to the Hospital for Sick Children. It was sold to Gerber. And the doctor who was a big part of designing pablum participated in these unethical nutrition studies. So, we're in full continuity with that. We're in full continuity with the forced sterilizations of Indigenous women that occurred in Canada and the US. And what I like to sort of think about with that is that we actually, we of the profession, we trained people to do that, right? It's a medical act. And we also, we also gave them a framework to act in quotes, ethically in what they did. And if you study that, you'll see that a lot of it has to do with the eugenics movement and so on. There are the Tuskegee trials, which I think this audience knows very much about, related to the natural history of syphilis and a similar story to the unethical nutrition studies in Indigenous people, but with African-American men. There's the history of the racism and psychiatry history of the Milledgeville Hospital in Georgia, which started to admit African-American people in 1867, and which there's a book that traces it, but just to sort of point out how it affects our knowledge, in 1867, when they were trying to explain mental illness in Black people, they didn't look at the effects of slavery as causative. They looked at the effects of emancipation as causative. So that's an example. And then we have the horrors of racial hygiene and Nazi medicine in Germany. And what's interesting from a professionalism perspective is that there was a reframing in the medical profession in Germany in the 1930s to explicitly include the concept of racial hygiene as one of the professional obligations in order to commit the atrocious acts. What about Flexner and professionalism? So, you know, Flexner Report 1912, professionalism is all about standards. And I think that it's fair to say that Flexner brought in the notion of standards of an institution to train people. And so he associated standards with accreditation. But this had big effects on equity, diversity, and inclusion. There were seven, I believe there were seven schools that were for African-American people that dropped down to 2 after Flexner, and similar idea with schools for women. So that's a well-known story. But there was also a kind of a racism that was in the constructing of who the doctor ought to be, which has been less well constructed. So Flexner advocated for segregation of care, different goals of training for doctors who African-American MDs who treat African-American populations versus white MDs who were expected to treat white populations. And I think the point of telling you these things is really to sort of say that we are in continuity with that history, and we may not have let it all go yet. And I think that this affects the diverse learner. You know, the learner who comes in to this professionalism and gets socialized in this professionalism can see a lot of tension between one's identity and one's professional identity. And in fact, in the last year, much has been written about this, and before. Croshoe has written about the racism experienced in the formal curriculum by Indigenous learners, for instance. And then much has been written. There's a really poignant article about, it's called Why I'm Leaving Academic Psychiatry. And it's written by Ruth Shim, and it's about structural racism in academic psychiatry. And for those of you who don't know, this is a picture of Downton Abbey, which is the show, you know, everything for me goes back to TV, as I told you. But I think that we are preparing and welcoming students very well who may be used to being in the living room of Downton Abbey, but not so well for the students whose parents and ancestors probably were in the kitchens, you know? And I think that we have to spend some time thinking about that as well. One of the things that occurs with professionalism is the notion of nostalgic remembrance. So I even may engage in it. Like I would say, you know, we were different in the 90s when I was training. But when we do that, we have to remember that the past that we're remembering is only being remembered through the eyes of those that were powerful in the past, right? So when we talk about some of this stuff, equity, inclusion, as something somehow new, I think we forget about some suppressed histories that may not have come out in the past. I think that we should avoid nostalgia as much as possible. We should look at the past as appropriate, but not as nostalgically. And in fact, for those of you that are interested, there's an interesting discourse analysis of how nostalgia is used in the NHS and National Health Service in Britain, is used as a tool of oppression, actually. And I can provide the reference if you need it. So now I'm just going to look at time. We're doing okay. I'm hoping to finish this talk by 12:30 or 12:35 at the latest, so that there's an opportunity for discussion. But now I want to think about where we need to go. Okay, and where do we need to go? We need to go to the notion of thinking about how we teach about diversity. Okay. I think about how I've taught about diversity from 1996 to 2020 or 2021 now. And I think in terms of still life portraits. In 1996, the still life portrait of culture would have been, look at the pretty colors, let's get you to appreciate and understand it. So the idea would have been teaching about cultural awareness. In 2006, maybe 2008, I would have said, look at this still life of culture. And I would have said, oh, but some of the fruit are exotic. And maybe to appreciate the fruit, the way that fruit has been painted, I might need to shine a different light on it. And that's the idea of cultural competence. In 2020, 2021, I think we have to teach people, what is the logic of this painting? Is it a still life? Is it an expressionist painting? Is it an abstract painting? Why are some colors in the front versus in the back? And I think that what we have to sort of get into in our medical school teaching around professionalism is looking at structures. You know, and one of the biggest ways to think about it, and this I'm indebted to Ramsden's work on cultural safety with Indigenous people, but is really to look at developing skills in cultural safety, viewing the medical act as occurring within a history where there may be structures of marginalization and oppression. So why is this patient presenting to me at this time with this problem? And how is this happening? And the way that I would sort of think about that would be, you know, and this is me thinking about an Indigenous patient, for instance, coming to my clinic. It would be, you know, disappointment was booked 400 years ago. And there's a whole series of cultural and social and colonial determinants of health that have led to the health problem. And I think we need to get our students thinking about that. I think what's missing in what we need to bring into the teaching is the notion of critical consciousness. So for those of you that don't know, this comes from Brazilian educator Paulo Freire, who was who wrote a book called Pedagogy of the Oppressed. And he got us thinking, and many of us in medicine are starting to discover him as someone to think about the way we teach. But he got us thinking about recognizing individuals as conscious, reflective social beings who can be aware of social contradictions and injustice, and who then develop a commitment to act to overcome injustice and oppression in partnership with the oppressed. So the idea here is that we need to think about notions of structural competence, reading the world, committing to act in terms of social justice. So then we would sort of be thinking about a professionalism of liberation and solidarity, acting with versus acting for or on populations, empowerment of populations, dialogic interaction with populations and patients, and a shared solidarity with patients. They need to help us obtain the PPE that we need by advocacy, as well as us needing to have solidarity with them. So what's missing? I think it's understanding the logic of our system, the racial hierarchies within our system, and the multiple different kinds of racism and discrimination that we see there. The patriarchy within our system, the heteronormativity and the transphobia within our system. And a real one that is really important to interrogate is the ableism within the way we teach people. And I think the way that we have to move forward is through deep listening. We have to teach students how to listen deeply. And deep listening is a kind of a way of listening that is attentive and generous and trusting. When we hear something that we don't understand, so that we can, you know, we can be willing to live in ambiguities and uncertainties as we listen and not be defensive about it. So if I look at the cases, and I think I have about 3 more slides. If I look at the cases and reanalyze them through some of the lenses that I just presented to you that might form a new professionalism, if we go to the case of Jamal, the boy who drowned, is noticing the pattern enough? Or do we have to construct professional identity such that there's a commitment to act. Maybe you're not the one who needs to act, but maybe you have a requirement to move that along in the ways that you can. In the case of Neville, who's the boy in the wheelchair, we constructed the behavior in discharge planning rounds as crossing lines. But here's the thing. I think that we can teach about the primacy of social context to health as part of a new professionalism. In the case of Bill, where we sort of could look at how the institution responded to what they saw, where they sort of said they stand in solidarity. I think one of the things that the institution didn't do was recognize itself as part of the colonization process for Indigenous people over a long period of history, that it needs to not only just stand in solidarity about, but to be committed to actively dismantle in partnership with Indigenous communities. So that's what a new professionalism would look like for me with these cases. So is it a contract or is it a covenant? So the metaphor of the social contract is used, and I think it's useful. And my absolute love affair with the Cruises, I really owe those two a lot. Makes it difficult for me to even talk about this. But the contract is, it's a metaphor. It helps us maybe get the idea of social responsibility in there. But when it becomes a theory, from a metaphor to a theory, I think we have to sort of see that it may be blind to notions of power, for instance. So I actually like the notion of covenant. And I'm not, I realize that covenant comes with some religious baggage that some may not like. But I like the idea of covenant because it's a binding promise. It's of far-reaching importance for individuals, groups, relationships between individuals and relationships between groups. And I think that that's what we're doing. And, whenever we have a covenant, there's always pain, right? Even when we were 6 years old and we swore on, we swore on our pinky a blood promise with our colleague, with our best friend, which I feel as a pediatrician, I have to say, don't do that anymore. But that, gets at the idea a bit better for me, what we're doing. So what I would say, I don't think that we have to change the guiding principles. These are the guiding principles from the International Charter, which really talk about the things we need to talk about: the primacy of patient welfare, the autonomy of the patient, and notions of social justice. I think we need to reformulate and bring in perhaps some new skills into that. And I think the two big skills that we need to bring in to what it means to be a professional are structural competence, the notion that we can appreciate healthcare structures as, and actually societal structures, as being constructed in ways that are unjust. And we do that through the skill of critical consciousness.
That's funny, the guys are chasing each other.
Sorry, somebody's talking. So the basic learning. So the basic learning objective is to appreciate that healthcare systems were designed to discriminate at times. And so when they're doing so, it's not by accident, but by design. And then in a critically conscious professionalism, we must be ready to dismantle. So I want to just point out some colleagues who have worked to help, I have worked with to help develop some of these ideas: Janet de Groot, Gia Merlo, Marco Antonio de Carvalho, William Agborbei, Preston Reynolds. And I put my two colleagues below as others because they're the conversations that we have had have included disagreement. So and some of the things that I want to point here is that some of this stuff may be controversial, but that the discussion has advanced very much my thinking as well. So with that, I want to say thank you. And I think I'm just going to look at time. We're at 12:30 exactly, which is when I wanted to end. and leave some time for commentary. And I will stop my share.
Thank you so much, Saleem. This has been a wonderful, thought-provoking presentation. We appreciate that. And now I'd like to invite the members of our audience here, the group attending, to put your questions into the chat, or you can unmute yourself and ask a question. Perhaps raising a hand would be a good idea. And then I can call on you and ask you to comment. I see Courtney Hagen has something she'd like to say. Courtney, could you go ahead and unmute and speak up? Oops, I'm sorry. That was not a hand raised. That was my own mouse over your, Courtney. So I don't mean to put you on the spot. My apologies.
No worries. I actually do have a question. I just wanted to first start with saying thank you for all those insights. And, you know, as a young professional who's still in school, what do you think is the most productive way to be able to enter their workforce and help make changes and impact change growing in the field?
I think the answer has to do with speaking up and personal safety. So I think that it is very clear that systems and structure-based thinking is not natural for me. It certainly wasn't what I learned when I went to school, you know, before penicillin and all of that. I'm just joking. But I think that what we have to do is this kind of speaking up with deep listening and compassion. And it's really, really hard to do, say, when you're on the receiving end of inequities, say. But I think we have to do that. And I do want to think about, I do want to sort of give the notion of safety as well when you speak up, and it's certainly been my experience. I think, and I can't see you, so I don't know if you identify as racialized or not, but I think if you're kind of like different and racialized and stuff, there's a lot more risk in speaking up in our institutions. So you have to actually think about that as you're speaking up.
Awesome, thank you.
I'm scanning the.
I see Audrey.
Hands raised.
Yeah.
Very moving talk, Saleem. Extremely thought-provoking, and commits all of us back to where we're here together and sharing in this space. I've been thinking a lot about how to use kind of restorative justice frameworks in the science of teaching and how to reframe how we teach. And I'm working with colleagues here to develop a curriculum, a faculty development curriculum, but wanting to frame how important it is in the context of this space for thinking about how to create an inclusive learning environment. And so I'm trying to situate structural competency and critical consciousness into doing that in an experience being very confined by, you know, time and hours, maybe not necessarily having, you know, the luxury to do it over a semester or that sort of thing. So I was wondering, do you have any examples or exemplar studies to guide us as we design programs in which we're really trying to bring awareness into the marginalization that occurs at every level of learning for how we teach?
So just in terms of, there's a New England Journal paper about racism in medical education that I think I don't have it near me or whatever, but I would put it in the chat, but I think it'd probably be easy enough to Google and find. But I think inclusion is an interesting concept, right? Because when I include you to my dinner party, do you get to bring a dish, you know, from your smelly dish culture, or is it, will you know how to use the forks, you know, like, you know, it's all those kinds of things. Like, so do you get to co-create with me or not, right? Like,
Yeah.
so
Yeah.
I think you have to have a kind of a bit of a reflection on that,
Yeah.
particularly with curriculum.
Yeah.
Because, like, are you going to listen? Like, you know, if you're the chair of the program committee of undergraduate medicine at your university, are you willing to listen to these students who, you know, or this patient population that is, you know, so I think you need to sort of have that reflection. I think that it boils down to a couple of things. It boils down to, I think the trigger warning idea is an important one.
Yeah.
So when I have, you know, one time when I talked about the unethical nutrition studies in Canada, I never did a trigger warning. And one of the students put up their hand and said, you know, my grandparents lived in those communities and were part of that. And it went well because he was very thankful that it was actually even being brought up or something, but it could not have gone well. So I think you have to look and say that my learners may be diverse as well in their experiences. And then the last thing is that I think you have to, and this is really hard. It's going to take a generation, I think, but we have to question the epistemology of science, right? Like, so when we have a journal club, and, you know, say race is identified as some kind of risk factor, you know, it's always identified as risk factor, you know, should the attending who's supervising that journal club say something like, you know, race isn't really the right word for this. It's being racialized as, or experiencing racism as, you know, or when I'm asked to review an epidemiology paper and they wrote race, should I, you know, in my reviewer's comments say, I think you should question how you wrote that, you know? I think it's those kinds of things.
Thank you, Andrea, for your questions, and Saleem for your comments. It looks like Sarah has a question.
Yes, thank you, Saleem, for a wonderful presentation. My question is similar to the one before, but I am an anesthesiologist. We don't round. So that setting for education of postgraduate training is not there. So also I am getting together the curriculum to start a more formal education, or, you know, continuing the education on professionalism. And I was wondering if you had any advice on how in the perioperative setting we could implement this, you know, creating more awareness. We don't have a lot of exposure to the social issues sometimes because the time is so limited and so specialized.
So, okay, so I'm a pediatric intensivist, so there's a little bit of overlap, but I would start with two things. The first thing is to look up all of the papers on how oximetry is inaccurate in dark-skinned individuals, and use that as an opportunity to discuss systemic issues. Like, you can use that as a case study of, you know, how it was designed, how technology is designed, how technology is tested, and how it may not have been inclusive in its design. That's sort of one thing. And then I think, you know, the other thing that really comes to mind, and this is, you know, for those of you that aren't in the world, this may be a bit jargony, but, you know, the big paper, Pediatrics recently, like the journal Pediatrics, that really showed the social determination of mortality for very mundane surgeries, you know, in children, like, you know, tonsillectomies and adenoidectomies, and the very, very significant racial differences. And I think that there's an opportunity there, if you review that paper, to talk about how much time we spend with different kinds of patients, what we explain to them, you know, like, just like there's much there. I don't know if that helps, but I'd be happy to talk to you about that afterwards.
Yes, that is fantastic. And yes, I will reach out to you, because this is perfect to to build my first group together with the interns, because since we have a new cycle, I want to start anew and see how we can impact the future.
Well,
Not sure who's next.
thank you for those questions. And we have several other people who would like to speak. Saleem, I'm going to start with one of the questions from the chat session. It's Brian Pilkington. And he says, great talk. Thank you very much. Could you speak to the notion of awareness with which you began your positive conclusions of structural competence and critical consciousness in terms of accountability? What responsibilities do you see practicing health professionals and those teaching future health professionals in fostering a covenant between patients and health professions?
Okay, so when I was sort of in the big bad old 90s, when I first started teaching about diversity and social difference and so on, I think what I was sort of trying to tell people was, be curious, be thoughtful to how people are different. And that's a great thing. And it's not to be poo-pooed, but what it missed was kind of like power. It was power blind, okay? And then when I moved on to this competence idea, I kind of, it's a great thing because you know what, it speaks the language of medical education. It says that, I can do an OSCE about working with an interpreter, and that, a Spanish interpreter. And that kind of works, but that kind of gave the idea that, you could know it all, whereas it's a lifelong practice. So then where we have come today, I think, is I think the major learning objective of today in terms of professionalism is don't view the healthcare systems as benign, right? Like I almost feel like saying it's kind of like unethical to teach medical students the healthcare system is actually a benignly constructed entity. It actually has a lot of badness in it. That needs to be appreciated. So then the skills then become like the covenant then becomes this kind of willingness to develop the skills to appreciate those structural issues.
Thank you again for your comments. And we have about 1 minute left. And I'm going to ask Gina Campilia, who has been waiting patiently to ask a question, to unmute and speak up.
Thanks. Sorry, with only a minute left, I'll try to squeeze in the question. So I'm an ethics consultant. I also teach the ethics curriculum for the medical students. And I think one of the things that I've struggled with is, while we shift our teaching to try to teach critical thinking, critical consciousness, structural awareness to students, at the same time, how they are evaluated along professionalism is in conflict with that. And so you often see, faculty who make anti-Black comments in the classroom, and a student speaks up, and then the student gets pegged as unprofessional. Maybe not in the long run, but maybe initially, and then there's correction. And so I wondered if you have any recommendations along the lines of how do we simultaneously shift our understanding of our expectations of professionalism for the students who are speaking out along these lines in the classroom.
It's not an easy one because it's actually an age-old thing, right? It's the, will I suffer negative consequences for speaking out thing, which happens all over the place and in all kinds of things. I don't agree with your clinical judgment or something like that. It could be a simple one. But I think what we have to do is protect students as much as possible to speak out, and that means building structures that are safe for them to speak out, and maybe they won't speak out in the moment. I also think it's teaching things like allyship, Because often in microaggressions, and so like the usual thing with microaggressions is they're directed at a patient, and then some student on the team identifies with the patient in some way, shape, or form. And then so they become a victim of the microaggression as well. And then there are these other students who don't identify, who are totally guilty because they didn't feel totally guilty because they didn't act in the moment. So I think what we can do is work on this kind of allyship teaching thing around these kinds of things that happened in the clinical environment. And really, they might, because if 4 students speak up, it's different than if 1 student speaks up, right? So that, not, perhaps it's a bit of a punt because I actually think it's a really difficult problem. But I think that's one way to start addressing it.
You have raised, thank you, Gina, and Dr. Razack, you have raised many good points for continuing discussion.